It's my pleasure to introduce my co-faculty here at UCSF, Dr. Matthew Garibaldi. Matthew is a chief orthotist and prosthetist here at UCSF, and he leads the ONP service. So Matthew, please take it away. Thank you.
So thanks, Sanjeev. This is fantastic, and really enjoyed participating with this webinar the last couple of years, and the talks have been great so far. Very exciting. So there's some overlap in what I'm gonna present with some of the talks that have been presented already, but obviously the focus will be more on our prosthetic care. The only disclosures I have is that I'm an employee of UCSF, and that this talk is largely based upon the work of a friend and colleague of mine, Michelle Hall, and her colleagues at Gillette Children's Specialty Healthcare in Minneapolis, St. Paul, Minnesota. And this is the article that I'll be referencing. So I'm just going to talk about congenital limb differences versus acquired. Prosthetic nomenclature, we'll go over that a little bit. I think many of you are aware of the basics of prosthetic care, so I won't spend too much time on that. Activity-specific prostheses, surgical considerations, some of which Dr. Mayer just presented, and upper and lower limb prosthetic milestones, as well as growth and prosthetic replacement. With regard to congenital limb differences, the incidence of an upper limb congenital difference is 2 to 3 times greater than that of a lower limb, with amniotic band syndrome being the most common etiology. Just advance my slide here. Sorry. There we go. A congenital transverse partial absence of the upper third of the forearm is actually the most common upper limb deficiency, while longitudinal deficiencies of the upper limb occur less often. Conversely, longitudinal deficiencies of the lower limb occur more frequently than transverse ones, with the most common being the longitudinal partial reduction of toes, followed by longitudinal deficiencies of the fibula and tibia. With regard to acquired amputation, traumatic amputations in children tend to occur twice as often as amputations from tumor or infection. In all age groups, finger amputations are actually the most common amputation. The peak incidence in toddlers due to door injuries. And adolescents are more likely to have injuries related to tools and lawnmower equipment. Traumatic amputations typically result in a transverse or complete amputation of a limb, and actually may be complicated by severe soft tissue loss or trauma to other parts of the body as a result of the injury. And of amputations associated with tumors, those that are those secondary to osteosarcoma or Ewing sarcoma actually occur with the highest incidence in the 12 to 21 age group. So again, just a quick prosthetic nomenclature overview. I think many of you are aware of some of this, but the upper limb prosthesis consists of a socket. This is the most intimate part of the prosthesis, is touching the residual limb. Some form of a suspension, which is usually a harness of sorts. The structure for a transradial prosthesis is usually the forearm, and for a transhumeral prosthesis is the forearm and the humeral section. And the terminal device, which is probably one of the most arguably important parts of the prosthesis, comes in the form of a hook or a hand. And the transhumeral prosthesis also has an elbow, as you can possibly imagine. Conversely, lower limb prostheses also consist of the socket and suspension. The structure in this case is endoskeletal in nature, so it's a pylon and a foot, and of course anything above the knee would require a prosthetic knee joint. So with regard to activity-specific devices, children who require prostheses are generally highly active and interested in a wide array of activities. So these activities often require the provision of a separate or secondary prosthesis with activity-specific components. And so you can see pictured here examples of upper extremity adaptive devices can include designs for playing a musical instrument and terminal devices designed for gripping bicycle handlebars. Examples of activity-specific components for lower extremity prostheses may include legs with carbon blades for running, swim legs, specialized knees for skateboarding. So some surgical considerations. And again, Dr. Mayer did a really great job of giving an overview on this. And I agree that the goal is really limb optimization. And so as prosthetists, our goal always in working with the surgeon is to balance the surgical priorities with the prosthetic goals of the family to provide the best possible outcome. So with respect to limb length, I agree that maintaining a long residual limb can result ultimately and usually in better strength and function. And in fact, joint disarticulations are fantastic. I agree, Syme level amputation is fantastic for most of our patients. It also can help minimize bony overgrowth. As you can see, this is a transtibial amputation with osteophyte formation, which is not what we want. I really like the idea of the cartilaginous cap in these cases, but if you have the opportunity to do a Syme or a longer amputation through the joint, I think that's always indicated. Some prosthetic components do require a shorter residual limb length to create sufficient clearance for their use. And so that's a conversation that you have with the family to understand what the desires are of the child. Maybe their athletic or activity background will help dictate and determine that length. But ultimately, the surgical level and limb length is dictated by the affected limb's joint stability, the bone integrity, and of course, the viability of the soft tissues. And Dr. Hamdi really brought this point home, and that is in the cases of congenital deficiencies, many of the families just opt not to undergo surgery for removal of non-functional anatomy, such as in this case of a partial foot or phalanges. This non-functional anatomy ultimately can be accommodated for in the prosthesis. As you can see here, this is a grown man with a PFFD and a relatively non-functional foot. But you can also see that it can complicate and limit the design and function and sometimes the cosmesis, as you can see in this picture, for future prostheses as the child grows. So with regard to upper limb milestones, sitting balance has been ultimately the traditional determinant for early fitting of a child with their first upper limb prosthesis. Typically, a passive hand is provided at this stage. In theory, the child will adapt to wearing the prosthesis so that by age 2, they're more amenable to learning how to operate a functional terminal device. And then by age 5, most children will be coordinated enough to control a body-powered above elbow prosthesis. It's super important to consider that wearing no prosthesis is also perfectly viable and acceptable option for children with upper limb deficiencies who are generally able to adapt and function independently without a prosthesis in many cases. And then older children with acquired amputation from trauma or disease will often adapt well to an upper limb prosthesis since they have lost function, sensation, and dexterity of an affected limb that they're used to or accustomed to having. So with regard to lower limb milestones, a little bit different. The ideal time is to start fitting a child with a lower limb prosthesis when they begin to pull to a stand. prior research suggests that a manually locked knee or a monolithic non-articulated pylon, as you can see pictured here, until about the age of 3 is indicated, or until the child can control a prosthetic knee joint. And I think that's intuitive and makes sense. But more contemporary research has actually demonstrated that early fitting of a prosthetic knee as the child pulls to a stand can actually provide significant advantages in early childhood development by allowing for kneeling, tall kneeling, reciprocal crawling. So we're in the process of making that considerational change in our practice at UCSF. And by age 2, most children walk with a heel strike, reciprocal arm swing, and a knee flexion wave. And then mature gait, including running, generally begins to appear around age 4. So final section here, growth and prosthetic replacement. Children will ultimately require a new prosthesis every 12 to 24 months. So they're skeletally mature. We're around the 12-month mark for most of our patients at UCSF. And just for comparison purposes, adult prostheses are generally replaced every 3 to 5 years, so significantly different replacement rate. For prosthetists such as myself, fitting a growing child is absolutely the greatest challenge, or the greatest challenges in designing a system that the child will not outgrow too quickly. And that is certainly an ongoing challenge that we face. And of course, as you can imagine, the prosthetist should always be consulted for modifications to the prosthesis to extend the device's usable life as the child grows and to accommodate any issues that might surface. Thank you very much for your time.